First up, I want to introduce Stuart, who's a hepatologist from Newcastle, who's first on.
Morning. Okay, thanks Pam, and thank you very much for the invitation to talk today. Moving back a step, so community testing initiatives to identify HCC surveillance candidates. I'll start with a few gentle warm-up slides, a bit of repetition, but no harm in that. So you're all aware that mortality rates from liver disease have been rising and have done so for decades. We have very high levels of premature mortality in parts of the country, particularly the north, where there's high prevalence of deprivation. What are the reasons for this? We have high levels of harmful drinking, rising rates of obesity that's contributing to more cases of steatotic liver disease, and we have a strong association between liver disease and deprivation. But as we've also heard, unfortunately, liver disease is frequently diagnosed late. The graph that you can see there shows work from Southampton, really showing that the majority of people who present with a complication of cirrhosis have never been seen in a liver clinic before, really showing there's clear lack of early diagnosis of liver disease. And we've also heard that only 20% of cases of HCC are diagnosed at an early stage. So we must do better to try and identify people early. So as the liver community, how can we reduce liver mortality? Well, we can identify people with liver disease early, before they develop cirrhosis, and intervene with lifestyle modifications or treatments to prevent them developing cirrhosis and hopefully improve prognosis. And we can survey for complications of liver disease, HCC, varices, etc. So here we move on to the NHS England Community Liver Health Check. So this is work, as Mukti's been saying, funded by the NHS Cancer Programme in collaboration with the Hepatitis C Operational Delivery Networks. And the idea is to develop good pathways for fibre scanning in the community to identify people with cirrhosis or those at high risk of liver cancer, and get them into surveillance. And once they're into surveillance, ensure that they are maintained in surveillance. And we also want to reach underserved communities, people in addiction services, the homeless, prison, etc., where we know there's high levels of liver disease, and often those people are harder to engage in care and maintain in care. And one of the other areas that Ryan's going to be talking about is peer and professional support to try and help maintain these individuals in surveillance. So how have these been delivered? Well, they've been delivered through the Hepatitis C Operational Delivery Networks. In phase 1, there were 11 ODNs involved, and that's been expanded to 18 now in the second year. And funding was available to these networks. It was a competitive application, and ideally for people to enrol people in HCC surveillance following diagnosis of cirrhosis through fibre scanning. And networks could use the funding for FibreScan technicians, nursing, admin support, pathway development. Some regions have vans, peer support. And the ask was for ODNs to deliver an additional 2,000 fibre scans. So not just scanning the people who are already scanning, but these are new scans over and above in the community. And that's risen now to 2,500 in the second phase. So who and where are people being targeted? So the criteria are more than 10 years history of excessive alcohol consumption, suspected or known alcohol-related liver disease or MASLD, or current or previous hepatitis B and C. And aiming to perform the scans in places not limited to drug and alcohol services, homeless shelters, primary care, diabetes clinics, prisons, community vans. And there's all sorts of places that people who might have liver disease are being scanned by all the networks. This is the pathway. It's simple. So those risk factors for liver disease, they have a fibre scan. If the liver stiffness measurement is greater than 11.5, then they're referred into a liver clinic for an assessment. And if HCC is appropriate and indicated, then those individuals will be enrolled in HCC surveillance. If people have a fibre scan less than 8.5, most networks are giving lifestyle advice, and that's it. And the intermediate group between 8.5 and 11.5 lifestyle advice, and then most networks are offering a follow-up FibroScan in 2 years. So what are the main outcome measures? Some easy to measure, others less so. So the number being FibroScan, the easiest measure, and I'll show you some of that data in a moment. Obviously, want to know the number and proportion of people who ultimately get referred into surveillance, and then critically those who attend surveillance and are maintained in surveillance going forward. But that data takes time to accumulate as people are not that far down the pathway at the moment. And probably the most important thing, ultimately, is the number and stage of liver cancers diagnosed. And that will take time to show the effects of this given the natural history of the disease. So here's some of the latest data, and this is a very busy slide, but the top line data is huge effort to scan more than 48,000 people across England, which is a remarkable effort from all the networks. And 9% of those people scanned have had a liver stiffness measurement above 11.5. So this is clearly targeting people who are quite likely to have significant liver disease. Lots of data here, but essentially really all I want to point out is that overall 95% of the national target has been achieved. There's been quite a variability across the regions, and the number of positive scans, actually quite significant variability from 5 to 22%, which requires a bit of teasing out as to why that is, perhaps where the people are being scanned. Further down the pathway, it's really too early to have any firm data because the data is incomplete at the moment. The first target there, number of people booked the first appointment, so the target that Mukti told you is above 80%, we're at 63%, but there is missing data here, so this is likely to be much lower than it actually will be. And then attending first appointment is 61%. Which is just above the 60% target. But I think it's fair to say this data is incomplete, and there are plans for the data, patient-level data, to be completed by end of June, to then do a formal analysis at that point in time to generate a justification for ongoing funding. So more data to come, but too early to give you detailed national data. I will, however, give you a snapshot of northeastern Cumbria where I can look at it in a bit more detail. So we, when I looked at this, had scanned 2,410 people, and 210 of those had a high FibroScan. Of those, 110 had completed investigation, and 39% had cirrhosis and have gone into HCC surveillance. And 51 cases of advanced fibrosis undergoing follow-up. And we diagnosed 2 HCCs, one was advanced and one was early stage. So a lot more coming in due course. The other area that is really just starting is a small pilot in primary care where a few GP networks are inviting people with the risk factors that we've already talked about in for a FIB4 score. If the FIB4 score is high, they come for a FibroScan. If it's intermediate, they undergo an ELF test, and if that's high, come in for a FibroScan. And obviously, if the FIB4 is low, they're reassured. And then same cutoffs really for FibroScan and into surveillance. But I think the thing to say about this is the data for using these tests in the community still isn't really there. The performance characteristics of these tests are different in primary care cohorts to secondary care cohorts. So we need to carefully analyse the data from this. But we also need to research better ways of doing this and better biomarkers, which brings me on to the SOLID study, which is a study that's happening in the northeast of England. We are recruiting 3,000 people from primary care who are going for their NHS health check or their diabetes annual review, asthma review, etc. And they have a liver assessment in this. And we're really looking at 2 pathways where they get liver enzymes, biomarkers, ELF, FIB4, and we're storing blood so that we can analyse for novel biomarkers. And then one pathway, they all get a FibroScan. The other pathway, only people with either a high FIB4 or a high ELF get FibroScan. And everyone with a FibroScan 8 and above gets reviewed in a clinic as a careful staging assessment ultimately to see if we can find better pathways, so incorporating new biomarkers, redefining cutoffs, ultimately to try and improve the pathway if we can. But a lot to do, and there's lots of other sites doing similar work, so it's a hot topic, and I'm sure in 5 years' time we'll have quite a different pathway that is probably much more precise than the current pathway. So that's a very quick whistle-top tour through. Any questions? A big thanks to all the networks. It's been a huge effort with hundreds and hundreds of people involved, and a really great effort that will, I'm sure, have measurable impacts, not just in diagnosing liver cancer, but actually bringing people in who hopefully we can do something to prevent them developing progressive liver disease in the future. So thank you for listening.